Hi, everyone, and welcome to this session on assessing the characteristics of and under-vaccinated children in low and middle-income countries, a multi-level cross-sectional study. This session is recorded, and we'll share the links with you after the session. This session is hosted by TechNet 21. During this presentation, you can ask your questions in the Q&A box, and the panelists will answer those questions after the presentation. You can tell us where you are from and who you are in the chat and during the presentation, and we'll be happy so that we can know who's attending. Thank you very much for your presence, and I'll give you the floor to Edson. Edson, the floor is yours.
Thank you very much, Alex, for that introduction. So, hi everyone. I'm Edson Utazi. I'm based here at WorldPop, University of Southampton. So WorldPop is a research program that focuses primarily on mapping human population distributions across the world. And we also look at various characteristics of human populations as well. So this piece of work, which I'll be presenting to you, was undertaken by myself and a number of WorldPop colleagues, including Professor Andy Tatum, who directs the WorldPop program. It is also a joint work with colleagues from Gavi, including Dan Hogan, who is on the call, and other colleagues from the Bill and Melinda Gates Foundation. Okay. Oops. Yeah, so it is often said that vaccination is one of the most successful public health interventions. And that's because since the introduction of the WHO expanded program on immunization, there have been remarkable increases in vaccination coverage around the world, leading to the elimination and eradication of vaccine-preventable childhood diseases in different countries. And in low and middle-income countries in particular, available data has shown that between 2000 and 2010, that progress was sustained. But in the period from 2010 to 2019, we began to see a slowdown in progress. We saw stagnation in coverage in different places, and even a regression in coverage in others. So in the midst of these fluctuations in vaccination coverage, a priority, sort of a challenge has been identified, particularly in settings that are attained relatively higher coverage levels. And that is how to reach the last 20% of children with routine immunization services. And this challenge has persisted because of all kinds of inequities that exist in vaccination coverage, geographical inequities, socioeconomic inequities, and even demographic inequities. As we see here in the figure on the right, shows substantial inequities in the proportion of underones estimated to not have received the first dose of DTP vaccine in 2019. In a country like Nigeria, we see that there's a lot of heterogeneities with the northwestern part of the country having higher proportions compared to the rest of the country. We also see a similar story in Chad, in Mali, in Somalia, in Angola, and other places. And so now there is a high level of interest in the development of strategies and interventions that target populations at risk of non-vaccination, otherwise known as zero-dose populations, as well as populations that are at risk of under-vaccination. And all the efforts that are being made are geared towards achieving the SDGs, the WHO's Immunization Agenda 2030, which aims to reduce the numbers of zero-dose children by 50% by 2030, as well as the Gavi strategy 5.0, which aims to reduce inequities in vaccination coverage by reaching zero-dose children and mixed communities. Okay, so we know that communities that are at risk of non and under vaccination often share certain attributes, and these include poverty, lack of access to healthcare and other basic services, civil or political unrest, poor vaccination practices, overcrowding, and so on. And so in 2017, the Equity Reference Group for Immunization, comprising of senior leaders in immunization sector, met and identified certain populations to be most at risk of non and under vaccination. And these are populations living in remote rural areas where access to vaccination services can often be a challenge. Populations living in urban slums where poor socioeconomic conditions, overcrowding, and so on could lead to poor utilization of health services, including vaccination services. And of course, children living in conflict areas where violent conflict events often cause disruptions to vaccination services. And so in order to target these risk groups effectively, we need robust and current evidence on their population sizes. We need to know their geographical distribution. We need to know their immunization levels and other characteristics. And so about 2 years ago, we started this work at World Pop to address this need, that is estimating the population sizes of these at-risk groups and their geographic distributions and other characteristics. And here we have an example output from that work showing the geographical setting with the most unvaccinated under ones in 2019 at admin level 2. And with this, in a country like India, so this would be mostly population living in rural areas, not remote rural areas, whereas in Somalia, this would be populations living in conflict areas, in Mali as well, conflict areas, and in Niger Republic, this would be populations living in conflict areas. And so in addition to this global scale work, estimating the sizes and geographical distributions of these populations, we also did this deep dive analysis to actually understand the nature of the associations, okay, that exist between these key community characteristics, that is remote rural, urban slum, and conflict, and the odds of non and under immunization at the individual child level. So this is meant to complement this global scale work. And this analysis was carried out when we don't control for other factors, and when we control for other factors that can also influence non and under vaccination in some low and middle income countries. Okay, so these were the variables, the outcome variables that we used to investigate non and under vaccination. And these are DTP1 receipt of the first dose of the DTP vaccine, DTP3 receipt of the third dose of the DTP vaccine, and MCV1 receipt of the first dose of the measles-containing vaccine. So we looked at these outcome variables independently, but simultaneously across some priority settings. And all our analysis focused on children aged 12 to 23 months. And these are the study countries, 9 of them, that we looked at in this work, some of which are priority settings for Gavi, and some of them we identified in previous work. Okay, so through literature searches and expert opinions, we assembled a number of covariate factors that we included in this work. So these are factors that could potentially influence non and under vaccination. And here we've categorized them based on the different levels of variation in the data that we assembled for this work, which I'm going to present as we go on. So we have the individual level variables: sex of child, birth quarter, whether the child was delivered by a skilled birth attendant, the number of ANC, antenatal care visits that the mother made while they were pregnant, and so on. Then we have the household level or maternal level characteristics that include maternal education, household wealth index, the religion of the household of the mother, the ethnicity of the mother. We have some communication variables, use of mobile phone and internet, and so on. And then we have the cluster or community level factors, which include these key community variables that we are interested in this work. So these are remoteness characterized using travel time, conflict affected areas, urban slums, and we have other geographic variables, which are region, the region of residence, and whether the family or the household lived in an urban or rural area. And there were other variables that we also considered, which didn't make it into our final analysis because they had missing data or because of some other considerations. These are variables relating to women's participation in decision-making, birth interval, and these malnutrition variables in particular tend to have a lot of missing data. Okay, so for these countries, we assembled data on from the most recent DHS survey that was conducted in the country. And these are the various countries and the years of the DHS data that we used. So the DHS years ranged from 2008, 2009 to 2018. And so from these data, we extracted information on the outcome variables and most of the covariates that we had seen earlier. And then importantly, for the key community variables, we assembled data from different sources. For conflict, data came from ACLADE, that's Armed Conflict Location and Event Data, which is an online database where you can obtain information on conflict events around the world. And then we had data on remoteness, which we obtained from the Malaria Atlas project based at Oxford University. And then the data on urban slums, we extracted from the DHS data. We created the urban slum areas using information from DHS data. And I'm going to talk about how we did that as we go on. Okay, well, first of all, let's look at how we processed the data on remoteness and how we integrated that with the DHS data containing all the other information that we needed. So this data relates to travel time to populated areas or cities with at least 50,000 people, and it was obtained at 1 kilometer resolution. As you can see here on the right, the red areas are areas that are far away from cities, and the blue areas are the cities or areas that are close to cities. So it was available at 1 kilometer resolution, and then we processed it for each DHS cluster location using standard approaches. So we would overlay the GPS coordinates, locations of each DHS cluster on these rasters, okay, to extract the value, the travel time at that particular location, and that involved creation of buffers around the clusters based on whether they were urban or rural clusters, and so on. So detailed information is provided in this paper given here. So once we finished processing this data at the cluster level, so the next thing that we did was for each country, we grouped the extracted data into 3 classes, okay, that we categorized as lower travel time class, medium travel time class, and higher travel time class. And this was done based on the theta of the travel time distribution within each country. And we have the example of the classified data, examples of the classified data shown here for 4 countries, for Ethiopia, Nigeria, DRC, and Madagascar. And you can see how the travel time distributions differed for each of these countries. So areas with higher travel times, the remotest areas are shown here in darker colors, and areas with lower travel times are shown in lighter colors. Okay, next we have the conflict affected areas. So we have some information here on how we defined conflict affected areas. So we obtained data on conflicts resulting in violent deaths within the 2 years prior to the year of each DHS. And that was because we were studying the 12 to 23 month age group. So wanted to capture conditions that were existing at the time that they were eligible, particularly for the DTP vaccines. So that was why we considered the 2 years prior to the year of each DHS. So that data was assembled and aggregated to the second administrative level within each country. And then we went ahead to classify each admin level as a conflict area if it had at least 30 deaths per 1 million population due to conflict. Okay, and then all the clusters fallen within areas at admin level 2 areas that we had classified as conflict areas were also classified as conflict locations. And in defining these conflict areas, this particular threshold of 30 deaths per 1 million population is what we refer to as the broad definition of conflict. We had a much narrower definition that we used in sensitivity analysis, which set the threshold to 300 deaths per 1 million population. So on the right here, we have the distribution of conflict areas that were identified in Nigeria and in Pakistan as examples. So these are shown in blue and in dark brown, where the conflict location also coincided with urban slums. So we've got a number of them here in Nigeria, and they're in Pakistan as well. So next, this was how we defined urban slums. As I said earlier, the data that we used for this came from the DHS surveys, but the definition that we used was the UN Habitat definition. And this involved identifying certain characteristics at a household level, which included lack of access to clean water, lack of improved sanitation, lack of durability of housing, and overcrowding. So we looked at the household level to identify these characteristics. And then each household was classified as a slum dwelling or a non-slum dwelling. So households that we classified as slum dwellings had at least 2 of these 4 characteristics. So once we finished this classification at the household level, we looked at the cluster level. So if at least 75% of the households falling within a given cluster were classified as slum dwellings, then we went ahead to classify that particular cluster. And these were only urban clusters because we're talking about urban slums here. So we went ahead to classify the urban cluster as an urban slum area. Otherwise, it was classified as a non-slum area. And so for Nigeria, the the clusters that were classified as urban slum are shown here in dark orange. And as I mentioned earlier, areas that coincided with conflict areas are shown in dark brown. So in Pakistan, there were very few of those particular, the ones that we can see here are those that also coincided with conflict areas. Okay, so just some information on how we coded the variables that we used in our analysis. So this is for the outcome variables, the three outcome variables, where we classified the no and don't know cases as 0, or coded them as 0 rather, and we coded all the other ones as ones. So our evidence of vaccination came from both vaccination cards and parental recall. Okay, and then just some information on how we coded these covariates as well. So in each case, we, wherever possible, we aimed to use the category that had the least likelihood of vaccination as the reference category, except where that category had a very small sample size, and then we would switch things around. In other cases, we just used a natural coding strategy where it wasn't possible to determine the category that could have the least likelihood of vaccination beforehand. Okay, so and here are some examples of the variables and how we coded them. Okay, so when we finished coding the variables, the next thing we did was to explore the patterns in the data that we had processed that involved calculating frequencies and percentages for each variable, and then estimating the percentage of missing data in each variable, and the criterion that we use to decide whether to keep or exclude the variable from the analysis was if a particular variable had more than 5% missing data, we did exclude it from the analysis because we didn't want to throw away a lot of information. And then one critical issue that we dealt with in this pre-modeling stage was the issue of colinearity. So this often happens when there's a change in the direction of the estimated relationship between a particular variable and the outcome variables between bivariate and multivariate analysis. So where that happened, we tried to identify the variables responsible for that, and we decided which one to keep and which one to exclude from the analysis. And of course, we used the generalized variance inflation factor in identifying multicolinearity in our data. And wherever necessary, we repeated these steps until we were happy with the way we had coded the variables, and we're happy that there was no remaining issue of colinearity or multicolinearity in our data. Okay, so once we were done with that, the first thing we did was to do bivariate analysis to understand the relationships between each variable and the outcome variables before we control for other variables. And this particular analysis was relevant for the key community variables, because we wanted to understand on their own the nature of the association that they had with non and under vaccination before we went ahead to control for the other variables. And this is normally done using this sort of model shown here, a simple binary logistic regression model. And this stage of analysis was done in a frequentist framework. In the end, we calculated the crude odds ratios and the corresponding 95% confidence intervals. So we accounted for the effect of other covariates in this multivariate analysis framework. So this is a standard model for doing this kind of analysis as well, but ours was implemented in a Bayesian framework, and in this timed Bayesian multi-level logistic regression model. And one other thing about this model that we used here, that we accounted for the various levels of variation in the data, the child level, the household level, the cluster, the community level, and the stratum level. So we included the stratum level to account for the survey design. I'm going to talk about that on the next slide. And because this model was fitted in a Bayesian framework, we needed to assign appropriate priors to the parameters in the model. And these included this prior on the fixed effects and this informative prior on the precisions of the random effects that are shown here. Okay, so why did we consider a Bayesian framework for this analysis? Is because within this framework, we have the flexibility to decide which approach to use for accounting for the sampling design. Okay, so we could either use the sampling weights directly within the model, or we could use the design variables which are clustering and stratification, both of which are already included in the model that I showed earlier. We chose to use the second approach here. In a frequencies framework, you could use sampling weights directly or the design variables as well to account for the sampling design. Okay, but the additional advantage that the Bayesian approach offers is that often when you're doing this kind of analysis in a frequencies framework, you could run into a problem at the household level, because in some countries, you may not have enough sample sizes at the household level to estimate the household level variation. So what some analysts do is that they exclude the household level from the model. So, but when you're considering many countries, it can be quite a pain, to look at each country's data to decide whether to include or exclude the household level. So, but in a Bayesian framework, you can just control for that by placing an appropriate prior distribution on that household level variance, okay, and that enables you to estimate it more robustly, whether or not you have enough data to do that. Okay, and our model was fitted using our INLA, which is quite popular for Bayesian analysis. And from the multivariate model framework, we calculated the adjusted odds ratios and the corresponding 95% credible intervals. And we have some metrics listed here that we used for model validation, which I will not go into, but anybody is interested in that can read about them in the manuscript. Okay, so here we have some results. First of all, the sample characteristics of our data. So these are the various countries, the numbers of children aged between 12 and 23 months that we found in the data, and then the number of complete cases that we had after we excluded those cases with missing data for at least one variable, and then the number of variables that we ended up with for each country after we had treated missing data and after we had dealt with the issue of multi-colinearity. And of course, the variations that we see in the number of variables is also due to the different questionnaires used for the various DHS surveys, because the data could have come from different DHS phases. Okay, so but in all, we had between 20 and 24 variables for these countries. So on the right here, we have the distribution of vaccination coverage at the country level for these three vaccines, vaccine dose combinations that we looked at, just to understand the different scenarios that are included in this study. So we have the lower performing countries, Ethiopia and Nigeria, and we have the higher performing countries, Zambia and Cambodia. And we have instances where we have large dropouts in DTP. When we look at DTP doses between DTP1 and DTP3, for example, and in Ethiopia, we have cases where the dropouts are smaller. So we actually captured different scenarios in our study. Okay, so here we have the results of the bivariate analysis, but shown here only for the key community variables, okay, which are remoteness measured using travel time, urban slum, and conflict. So when we look at the results that we have here for remoteness, we observe that remoteness increased significantly the odds of non and under vaccination in all the countries, except in Mozambique, where the relationship appeared to be in the opposite direction. So what we're seeing here is that children living closer to cities were more likely to be vaccinated, okay, compared to children living in more remote areas in all these countries. Okay, and then moving on to conflict, the effect of conflict on non and on the vaccination. In these bivariate analysis, we found that living in a conflict-affected area significantly increased the odds of non and under vaccination in Ethiopia, in Madagascar, as you can see here, in Pakistan and India, but this was only for DTP3. So there were cases where we found significant associations between conflict and non and under vaccination, but the relationship was in the opposite direction. Okay, as we can see here in Nigeria, for example. In other cases, the estimated relationship was not significant, as we can see here in Mozambique. So as I mentioned earlier, we had this narrow conflict definition. So for Nigeria, we actually sought to understand why we were getting the estimated relationship in the opposite direction when we were using the broader threshold. So there we did additional analysis using the narrow definition, that is 300 beds per 1 million population, to classify an admin level 2 area as a conflict area. And we found out that for Nigeria, the relationship reversed. Okay, so we found a significant association between conflict and the odds of non and under vaccination. So conflict increased the likelihood of non and under vaccination when we used the narrower conflict definition, but the reverse was the case when we used the broad conflict definition. So also in bivariate analysis for urban slums, we found that living in an urban slum increased the odds of non and under vaccination in Pakistan and India, but this was for DTP3 only. So out of these three community level variables, we found the strongest evidence in bivariate analysis for remoteness. So we did find some evidence with conflict, but the evidence that we found was weakest for living in an urban slum area. And we did an additional sensitivity analysis for urban slum areas to actually understand whether children living in urban slum areas had higher likelihood of non and under vaccination compared to those living in formal urban areas. So we categorized this urban slum variable differently. Here we're using living in a slum area versus living in a non-slum area. But with the categorical variable, we have three categories, and those were formal urban areas, urban slum areas, and then rural areas. And we did find out that in most cases, living in an urban slum compared to living in a formal urban area increased the likelihood of non and under vaccination. Okay, so here we have the results from the multivariate analysis when we now control for all the other variables in our study. Okay, so here for Madagascar, in multivariate analysis, remoteness still remained a significant predictor of non and under vaccination. But in addition to that, we have several other variables, health-related variables and gender-related variables. Variables like the number of antenatal care visits that the mother made, when they were pregnant, whether the child was delivered by a skilled birth attendant or not, and the number of tetanus toxoid injections that the mother received before birth. So the evidence here shows that mothers with no ANC visits, children born to such mothers had higher odds of non and under vaccination. Children born to mothers who had no TT injections had higher likelihood of non and under vaccination. And then we also have other variables here at the top, gender-related variables, maternal education, with children born to mothers who had no education having a higher likelihood of non and under vaccination. We also have religion there, and yeah, just education and religion there. Okay, so we have another example from Nigeria here. So for Nigeria, even though in bivariate analysis, we found a significant association between remoteness and the likelihood of non and under vaccination. In multivariate analysis, remoteness was no longer significant. And out of all the key community variables, it was only in the case of DTP1 that we found a significant association between urban slum and the likelihood of non-vaccination. Okay, so but just like Madagascar that I had shown earlier, okay, so these variables related to maternal utilization of health services continues to remain significant. We have skilled birth attendants there, ANC, tetanus toxoid vaccination, and so on. So, and we have some other gender related variables as well, maternal education, religion, ethnicity, all being significant predictors of non and under vaccination. So here we attempted to summarize the results that we observed and the multivariate analysis. So dark blue there showing variables that had significant association with the outcome variables, light blue where we don't have significance, and gray there where the particular variable was not included in the analysis. So in general, when we look at the ranking of these covariates based on the proportions of countries that they were significant in, we see that these variables related to maternal utilization of health services were consistent predictors of non and under vaccination across the three outcome variables. We also see the gender-related variables as well, maternal education, ethnicity, and religion all being higher ranking predictors of non and under vaccination compared to these key community level characteristics. In bivariate analysis, we found significant associations between remoteness and non and under vaccination. But here we can see that in the presence of all these other variables, remoteness is not a high ranking predictor of non and under vaccination. Okay, so in summary, I realize that we're almost out of time. Yeah, so in bivariate analysis, we found evidence that remoteness and living in urban slums and conflict-affected areas increased the odds of non and under vaccination, and this evidence was strongest for remoteness. Okay, but in multivariate analysis, these key community variables were sometimes associated with non and under vaccination, but they were not frequently predictors of these outcomes as we had expected. Rather, we found several gender-related factors, including maternal utilization of health services, maternal education, and ethnicity were more common predictors of non and under vaccination. Let me just take this opportunity to highlight that the study had some limitations, which include a potential underrepresentation of urban slums, particularly in DHS surveys, and perhaps maybe inadequate data on conflict affected areas as well, which may have affected the results that we obtained in the study. So thank you very much. I'm going to stop here.
Thank you very much, Edson. Is there any question? Is there any question? Don't hesitate to ask your questions in the Q&A. Carolina, I'll let you moderate the questions. There's already one.
Thank you, Edson. I think maybe we can pass the floor to Nicholas so he can ask. I'm not sure if Nicholas can unmute himself.
No, he can't. Let me find him. Give me a second. Nicholas Danielson and Nicholas. Okay, Nicholas, you should be able to unmute yourself.
Okay, thank you. Can you hear me?
Yes.
Okay.
Go ahead.
Yeah. So my question is about the remoteness variable that was used. This variable of the distance and the travel time to an urban area with more than 50,000 inhabitants. What are the implications? What does that really say? Because we often look at the travel time and the distance from the home to the health facility, to the vaccinating health facility. So how good of a proxy is that to for an association between the time it takes for parents to get to a health facility where they can vaccinate? And yeah, that's my question really.
Yeah, thank you very much. That's a really good question. So yeah, as you said, we used travel time to cities as a proxy for remoteness, because we know that in remote rural areas, okay, so health services, including vaccine services, tend to be poorer than in urban areas. So that's part of the rationale behind the use of travel time to cities. But as you mentioned, one could also use travel time to the nearest health facilities to measure remoteness. So, but oftentimes the data that exists on the locations of health facilities which are used to produce travel time to the nearest health facility is often incomplete, has a lot of inconsistencies. Okay, so and right now we're actually looking at using travel time to health facilities to sort of redo this analysis and then to look at how the results compare with what we obtained with travel time to cities. So yes, one could also use travel time to health facilities, but you've got to bear in mind that the data available on the locations of health facilities might have a lot of issues, because oftentimes you know the location of a health facility, but you don't know whether they actually offer vaccination services or not. So we are looking at that currently. Thank you.
Thank you, Edson. If I may comment on this, do you see any benefit or like a different type of analysis that can be done now that WHO has this list of georeference health facilities with more information about each one of them? So that's my question about the point that Nicholas raised and the analysis. And I think I'm going to ask immediately my other question is that.
Sorry, can you clarify that first question again?
Yes, whether you think that with the list of health facilities georeference that now exists through WHO, how this can help this type of analysis, and what can we do differently now that this massive resource of health facilities georeference and with characteristics exists? So that's my kind of follow-up questions to Nicholas. And then I have a comment because when I read this paper, in a way, it goes against what we have been saying, right? We have been focusing on these three types of settings, where your findings seem to indicate that many of the individual level factors are more related to the likelihood of not being vaccinated. If you can comment on that, thank you.
Yeah, thank you very much. I think that was one of the striking things that we saw in the results, because we thought that both in bivariate and the multivariate analysis that we will end up with results that show that these key community variables, that's remoteness, urban slum, and conflict areas, will be top predictors of non and under vaccination. And we're kind of a bit surprised to see that in the presence of other variables, that they were not top ranking predictors of non and under vaccination. So it's kind of interesting, and I think that in addition to focusing on those communities, those at risk communities, we should also be looking at the other factors. Those are the gender related factors, as those are also important determinants of non and under vaccination. And it could be the case that actually a great proportion of unvaccinated or zero-dose children live outside of these settings that we are focusing on currently. Yeah, I don't know, maybe Dan may want to say something there as well.
Yeah, sure. I mean, I think Carolina, we had a similar reaction on looking at these, but I think a couple of points on that. I mean, one is that like another paper that Edson and colleagues at World Pop are working on, I think is around a little less than half of zero dose live in across those 3 ERG settings. So it's a substantial number, but not maybe as much as we might have thought. I think two other things to consider. One is how accurate are the data for measuring sort of the situation? Surveys, are they really capturing what's going on in conflict areas as well as slums? And then I think another thing to think about with this is it's interesting with the multivariate analysis, because you're conditioning on the different variables, and so it could take something like remoteness. There's clearly a very strong association with maternal health care services, and I think we've seen that in other work, for example, from University of Pelotas, which makes sense. But it could be that in a remote setting, you're not getting access to immunization or those other services. But when you're conditioning on those variables, then some of the other ones disappear. So it doesn't mean that households in remote areas aren't getting access to any of those services. It's just, I think some of that, the multi-level modeling from a sort of causal inference perspective sort of gives you one view, but then if you're thinking about where the populations that are suffering the largest sort of deprivation from getting access to services could be still clustered in some of these places. So I think there's sort of two lenses to look at. There's sort of that bivariate, or even just overlaying the different GIS layers to understand where these population groups are that are missing health services, and then there's sort of the more causal inference view of like what is the reason for that across the sort of household and community level factors. Yeah, I agree though, it's an interesting finding for sure from the study. Thanks.
Okay, thank you very much, Dan. Yeah, going back to Carolina's first question, I will give the same response that I gave to the person that asked the same question earlier. Yeah, so now that we have better data available on locations of health facilities, yeah, it will be interesting to actually repeat this analysis using travel time to health facilities to understand what the differences are between what we're going to see and what we are seeing currently using travel time to urban areas or cities. So we'll be looking forward to, we're already doing that, and we'll be looking forward to seeing what the results look like. Yeah, thank you.
Thank you. I wonder if we can give the floor to Meseret and then Ana Maurice.
Okay, give me a second. I'm looking for Meseret, sorry. Meseret. Meseret, you can unmute yourself.
Thank you so much. A very interesting evidence, really. We personally, I appreciate. It is very stimulating. My comment is to allow representation of these special populations. All right, I'm talking of the urban population, and also the remote population. What type of survey assessment should we do? Okay, because the DHS may not even pick them, you know, when you systematically or randomly pick, these communities may be underrepresented, all right? So in our equity assessments, maybe targeted surveys, but done in a standard manner could help us really generate the evidence and come out, because the administrative result is not really making sense for us. So it's just a concern how we can have a guided standard survey, which we could be part of the equity assessment. So I would love to hear from the different experts, really. Thank you. Over.
Okay.
Thank you, Mr. Ed. I think I'll take this one because the next person who is going to take the floor with Ana Maurice is actually working with us, WHO, on guidance for targeted surveys. And the first part of the guidance is really how to even define where you want to do a targeted survey. So using the data you already have to do some triangulation and then do the survey. So I'll pass it to Ana. So, well, first, I don't know if Edson or Dan want to comment on that, and then to Ana, please.
Anna, you can speak. I've just unmuted yourself.
Okay, can you hear me?
Yes, very well.
Okay, thank you. Yes, as Carolina was mentioning, we are developing a toolkit, and the first thing is to identify where are those areas. So this information is very useful, and also mapping will be a great tool to identify where they are located. That's the first step, and based on that, we can move forward to characterize the population and go through the next steps. I had another question related to prenatal care, because it seems that the health service access to during the prenatal care is a very strong related variable. But I wonder if you also analyzed other demographic variables related to the mothers, like the age or the educational level, because we conducted some analysis using mixed UNICEF surveys, and the health access is determined by demographic characteristics of the mother, like the age and the social support. So I was wondering if you have any findings about those type of variables.
Yeah, thank you very much. As you rightly observed, so maternal access to health services came up in our analysis as a very strong determinant of non-vaccination and under-vaccination. So we did look at other maternal characteristics, for example, education level that you mentioned, and it also came up as being a significant predictor of those outcomes. And what we think about these is that, you know, all of these results sort of point towards integrated delivery strategies, okay? So strategies that are targeting improvements in maternal utilization of health services should also target improvements in vaccination coverage levels, because both are closely related. So yeah, I don't know if Dan wants to add anything to that.
No, I think that covers it. Thanks, Edson.
Okay.
Carolina, there's a comment. There's another comment in the Q&A box. And I see Nasir Yusuf is raising his hand. So tell me.
So please to Nasir, and then we go with the other comment.
Okay. Nasir, I'll give you the floor. You can speak.
Okay, on mute.
Yes.
Okay.
We can hear you.
Yeah, thank you very much, Edson, and thanks, Alex. Mine is about the correlationship between lack of TT injection before birth, and non-immunization, which is, I would interpret that to mean 0 dose. So it means there's this very strong relationship between the possibility of a particular area being at high risk of neonatal tetanus, maternal and neonatal tetanus, and the relationship with 0 dose. Unfortunately, when we talk about 0 dose, we just narrow it to the child. But I think it's right time we start also considering other risk factors like communities where you have the possibility of, you have high risk of having maternal and neonatal tetanus. Maybe this should also become one of the indicators we should be looking at when we're talking about 0 dose, so that we don't just keep the narrative at the level of the child. Thank you.
Yeah, thank you very much. Yeah, I think that assumption that we found could also mean that areas where mothers are not getting TT, areas with lack of access to essential health services, including vaccination services, and that is also seen in children living in those areas. So I do agree with you that we should be looking at such areas, yeah, when both factors actually, yeah, when designing interventions, yeah.
And do you want to comment on that too?
Yeah, no, I think that's just the importance of sort of always referring to 0 dose and missed communities. So I think there's that, it's understanding that all the other, the relationship with other, related health services. And I think for a lot of these households, they're missing on several of them. And so it's useful to pay attention to more than just one indicator to understand that. So I very much agree.
Thank you. I think this is one of the main reasons I wanted to have this webinar with all of you, because it's time to think of the so what, right? Like, what do we do differently now that we have more evidence, that we have more information? And I think now that we have less resources globally with the pandemic and the constraining health systems, food problems, etc., we are going to have to do more with less. And I think we'll have to figure out how we target, how we dig deep. And I want to invite you all to read this paper, think of how these questions can be answered in your own settings. As you saw, some of the surveys had very few unvaccinated children, like very few 0 dose. So it's also tricky to even monitor this in community, in places where the zero dose children are mixed within the community, not really clustered. And probably we'll have to think differently how we go about it. Tetanus toxoid during pregnancy or in women of childbearing age, depending on the schedule, is going to be critical to figure out how we use that opportunity maybe to better target for the future. We are running out of time, so I think that it's recorded. So please, if you have any questions, just email them, send them. And thank you so much for joining, and thank you, Dan, and thank you, Edson, for sharing this important study with us, and looking forward to the other one you mentioned that is in progress. So thank you so much, and goodbye, everyone.
Thank you very much. Goodbye, everyone.
Thank you.
Thank you. Goodbye, everyone. Bye-bye.
Bye-bye.